Module 2, Cognitive and Psychological Symptoms Related to Concussion. Patients sometimes present with cognitive and psychological complaints after receiving a mild TBI. Reports such as, "I just don't feel right," or "my brain is not as good as it used to be," are often heard from patients. They may feel as though their thinking has become slowed or unclear, or that they're just not feeling quite all there. Complaints after mild TBI can be largely influenced by perceptions and appraisals. Therefore, complaints may not accurately reflect true chronic issues. It's estimated that only 10 to 20% of mild TBI patients experience chronic cognitive problems after injury. And it's still unclear whether this results from the injury itself or other comorbid factors. In fact, many studies have found that when emotional issues are taken into account, cognitive problems thought to be related to TBI are in fact attributable to these other disorders. We will discuss potential comorbid conditions later in this module. Following a concussion, people sometimes experience difficulties with attention and concentration. For example, feeling easily distracted or having difficulty multitasking. Patients may feel as though they need to reread material more than once or have a hard time tracking conversations. Memory, such as post-traumatic amnesia, in the acute phase of injury may last up to 24 hours. Sustained memory problems, assessed through neuropsychological testing, occur in approximately 10 to 20% of patients. Processing speed refers to the speed at which an individual can process and understand information. After a brain injury, patients may notice slowed reaction times. Executive functions encompasses a wide array of higher order cognitive processes that help us plan and direct behavior. You can think of these as the set of skills a manager or executive would need to carry out their job. They include planning, problem solving, fluency, inhibitory control, working memory, organization, and flexible thinking skills. Difficulties with executive functions are commonly noted by family members or friends observing the patient's behavior, rather than by the patient themselves. They may notice the patient may be difficult to keep on topic during a conversation. Inhibitory control deficits, such as frequently interrupting others while speaking, may also be noted. Patients may also make decisions that do not appear to be well thought out or planned out. One helpful assessment tool to assess the above symptoms is the Neurobehavioral Symptom Inventory, or NSI, attached in the resource section. Following administration of the NSI, it can then be useful to clarify each symptom, including duration. For instance, how long have you had trouble with feeling as though you cannot pay attention to things or that you're easily distracted? Frequency. How often do you notice this happening to you? Do you ever have days that you feel that you don't experience problems with concentration? Onset and triggers. Are there common times in which you notice that you're having trouble with concentration? For example, does it happen more often when you're stressed or tired? Intensity or severity. How severe would you say your poor concentration is? For example, it can range from mild, meaning that it does not impact your life too much and you can typically continue what you're doing, to very severe, in which you're unable to perform any tasks or everyday functions without assistance. Something more in between these two would be moderate, where you can continue your activities but with some effort. Impact on functioning. How has your concentration affected your work or your social or leisure activities? Are there any areas of your life that you believe would be different if you did not have difficulty concentrating? Finally, exacerbating factors, including medications, caffeine, tobacco, sleep, and co-occurring illnesses. Be sure to get examples of each of these impairments. We often notice that patients report vague concerns about memory and attention, but then sometimes can't provide examples of these impairments and how they affect their day-to-day functioning. Deficits can be seen in the first 3 months following injury, and then patients typically return to normal levels of functioning. Long-term post-concussive symptoms are not the norm, though a small minority of patients continue to complain of cognitive deficits. One thing that we will highlight throughout this training is to frequently check in with your patients about their perception of symptoms and expectations for their course of recovery. We have found that patients who have sustained a TBI are often anxious about their diagnosis and have many misperceptions. For example, they think symptoms related to a concussion are long-lasting and irreversible. The term brain injury itself is frightening to patients, so we prefer to use the term concussion. When patients imagine injury to the brain, they make assumptions that there will be cognitive changes, often likening it to dementia. One of our roles in managing TBI is to clear up these misperceptions. Providers can communicate to patients that the majority will see complete resolution of cognitive symptoms within 3 months. It's important to note that sustained symptoms after the 3-month mark may be due to other comorbid or exacerbating factors rather than the head injury itself. In the resources section, there's a role play of a provider educating a patient about concussion and cognitive symptoms. In addition, keep in mind that there's little correlation between actual injury severity and patient self-reported cognitive problems. Research has shown that medical professionals tend to overestimate the accuracy of self-reported symptoms, which in fact may not be true representations of objective cognitive abilities. Discrepancies may occur when patients overestimate their pre-injury functioning, which allows for a heightened sense of impairment post-injury. This is not to say that patients may not be suffering from cognitive symptoms after a TBI, but rather to point to the importance of recognizing the limitations of self-reports. This makes our job as PCPs particularly challenging. However, this does not mean that a referral for neuropsychological testing is necessarily warranted either. One recommendation here is for the PCP to focus on degree of impairment and change in work or school functioning. Clinicians should use principles of risk communication to ensure that patients are fully informed regarding their injury and projected recovery, so that they may share in the decision-making process throughout the course of treatment. Risk communication can also be an opportunity to provide reassurance, promote normalization, and minimize the perception of disability. Cautious risk communication also will help reduce the perception of neurologically based deficits and will guide treatment based on symptoms and functional needs. Education should include information about the potential effects of coexisting conditions and medication side effects on cognitive functioning. Next, we will discuss common emotional symptoms seen after a mild TBI. Emotional symptoms are important to acknowledge for 2 reasons. First, they cause the patient distress and may need to be treated in and of themselves. Second, emotional reactions toward injury may affect an individual's cognitive functioning and adjustment post-injury. Depression may develop as patients are confronted with impairments following their TBI. They may struggle with feelings that they're now damaged or limited in multiple facets of their lives. Anxiety commonly occurs when patients perceive both real or imagined impacts of their injury. They may fear that they will never return to normal or fear becoming injured again. These feelings of anxiety and worry may lead patients to overestimate their deficits or underestimate their recovery process. Irritability or agitation may arise as patients learn to cope with the emotional and/or cognitive symptoms of their concussion. Patients may be easily irritated by interruptions due to impaired concentration and increased distractibility. Common complaints are that others, especially clinicians, don't understand the extent of the individual's injury or distress, don't know how to heal them, or simply don't care about the patient. Patients may also feel a sense of anger or injustice over their injury. Impulsivity may be observed, especially if executive functions have been impacted. Patients may notice difficulties with impulse control or fail to see the long-term implications of behavior and decisions. There may be increased risk-taking or lack of appropriate boundaries. Aggression occurs hand in hand with increased anger and irritability. Family members and others close to patients may report that they appear more short-tempered. This, coupled with increased impulsivity, may increase the likelihood of verbal outbursts or even physical aggression. When assessing the severity of psychological symptoms, it's important for PCPs to remember that some patients may be reluctant to report symptoms. Factors such as stigma against mental illness may contribute to this reluctance to discuss emotional concerns. Certain groups, such as individuals from rural communities, service members, veterans, men, and racial or ethnic minorities, may delay or avoid seeking help for issues related to mental health stigma. This stigma may lead patients to heavily rely on primary care providers instead of seeking help from mental health specialists. Therefore, it's important for providers to understand the common psychological presentations of their patients. Some psychological symptoms may present as somatic complaints. For example, patients may not forwardly state that they're feeling anxious, instead reporting recurring stomach aches, dizziness, or tightness in the chest. A patient may report feeling tired and experiencing changes in appetite, instead of saying, "My mood has been low and I feel hopeless." Reports of pain may increase as well, especially when accompanied by comorbid psychological symptoms, such as post-traumatic stress symptoms. On the other hand, while some patients may not be reluctant to discuss psychological symptoms, they may just not think to bring up these concerns with a primary care provider. Asking a few simple questions regarding the patient's mental health may allow PCPs to be a crucial first point of contact to direct patients toward mental health resources. Assessment tools to assess the emotional and psychological symptoms commonly associated with mild TBI are provided in the resources section and include the PHQ-9 to screen for depression, the PC-PTSD to screen for PTSD symptoms, and the GAD-7 to assess anxiety symptoms. Researchers estimate that between 26 and 47% of patients with mild TBI also meet diagnostic criteria for a secondary disorder. This comorbid presentation contributes to higher rates of impairment. Comorbid or competing conditions should be considered when patients fail to show symptom improvement within 1 to 3 months or if they show significant deterioration in functioning. Addressing comorbidities may also have a positive indirect effect on post-concussive symptoms. PTSD or similar trauma-related disorders may accompany a concussion if the injury involved an event that was psychologically traumatizing. Common examples include accidents, such as motor vehicle accidents, domestic violence, combat, or physical assault. Despite the multitude of events that may lead to comorbid TBI and PTSD, most studies examining the disorders concurrently use samples of military personnel or veterans. One study found that 44% of U.S. soldiers returning after deployment to Iraq screened positive for both mild TBI and PTSD. PTSD and mild TBI have a great deal of symptom overlap. Both conditions are associated with symptoms including difficulty concentrating, memory loss, irritability, impact to social relationships, and sleep disturbances. Although research findings are not entirely consistent, the majority of studies have shown that patients with both mild TBI and PTSD do not appear to experience worse cognitive outcomes compared to those with either mild TBI or PTSD alone. However, comorbid mild TBI and PTSD are associated with more mental health problems and problems with social and work functioning. Research has shown that following a mild TBI, approximately 15% of adults will also experience a depressive disorder. Both depression and mild TBI are associated with apathy, memory problems, mental slowness, concentration difficulties, appetite changes, fatigue, sadness, difficulty with decisions, insomnia, and irritability. Depression is a risk factor for poor recovery after mild TBI, and patients who experience depression post-injury may report more post-concussive symptoms and more severe symptoms. Substance use is frequently seen with mild TBI. In some cases, substance use predates TBI, making individuals more susceptible to sustaining a head injury. For example, adults hospitalized for TBI tend to drink much more heavily compared to their peers who have not incurred a head injury. A survey conducted by the Colorado TBI Surveillance and Follow-up System found that 21% of individuals admitted to Colorado hospitals for a TBI were intoxicated at the point of injury. Research has shown that between 10 and 20% of people with traumatic brain injury develop a substance use problem for the first time after their injury. Considerable symptom overlap can be seen between mild TBI and substance intoxication or withdrawal. These include sleep disturbance, irritability, and difficulty concentrating. Physical or somatic complaints such as sensitivity to light and noise, trouble with balance, nausea, dizziness, fatigue, and blurred vision can also be observed in both conditions. Substance use after head injury can be problematic for several reasons. Patients who use alcohol or other drugs tend to show slower or even diminished recovery, as well as greater disability. In addition, both alcohol and drug use are associated with worse TBI symptoms, such as difficulty with balance. Substance abuse also compounds other symptoms, such as impulsivity, difficulty with concentration and memory, as well as feeling low or depressed. Finally, substance use puts patients at greater risk for future head injuries. Patients with mild TBI may experience physical, cognitive, and emotional symptoms that then place them at higher risk for suicide. Research has found that the risk of suicide in individuals diagnosed with at least one mild TBI in their lifetime was 2 times higher compared to those without head injury. It should be noted that death by suicide among participants in these studies was extremely rare. However, participants with TBI showed higher risk for suicidal ideation and suicide attempts. Providers should be aware of this increased risk in patients with a history of head injury and closely monitor for red flags suggesting potential suicidal ideation. A common method used in primary care is monitoring self-report assessments. The PHQ-9 mentioned previously in this module has questions to screen for suicidal ideation. Research has shown that between 30 and 70% of patients experience sleep problems following a TBI. Interestingly, sleep disturbances are reported at much higher rates in patients with a mild TBI in comparison to those with a severe TBI. Poor or disrupted sleep quality is also a complaint in many of the comorbid conditions typically associated with mild TBI, such as PTSD and depression. Sleep is involved in physiological processes underlying neural recovery, playing an important role in functional outcome and resolution of symptoms. Sleep disturbances tend to outlast the emotional symptoms of mild TBI and are the main contributor to other symptoms even years after injury, which may serve to complicate recovery. Following a head injury, patients often complain of pain, with headaches being the most commonly reported pain symptom. Unlike other post-concussive symptoms, pain has not been found to be explained by other comorbid conditions, such as depression or PTSD, suggesting an independent physiological link between pain and TBI. Surprisingly, again, pain prevalence rates are much higher in patients with mild TBI compared to those with moderate or severe TBI. Patients with pre-existing headache syndromes typically report worsening symptoms after sustaining a head injury. Pain and mild TBI are often associated with similar cognitive impairments in the domains of attention, memory, and information processing. The co-occurrence of pain and TBI may cause additive disruption of cognitive emotional regulation centers in the brain. Similar to other comorbid conditions, pain can make it difficult for providers to adequately assess the true impact and severity of TBI symptoms alone. Researchers have found pain to be a significant predictor of poor functional outcomes following TBI. However, providers should be mindful that no evidence-based practices currently exist for managing pain in TBI patients. Despite this, it's not uncommon for practitioners to prescribe opioids to treat or manage chronic pain in TBI patients. It's important to note that opioid therapy is contraindicated in patients with TBI with neuropsychological impairment.